Okay, alignment and motion. So incorrect centering and an angle on the tube can cause shape distortion. This is nothing new. We did this in the lab too, right? We actually didn't even angle the tube. We just misaligned. There's a slide like that in here coming up soon. And we know that angling will elongate the object and thus cause shape distortion, which is different than size distortion, right? Size means everything increases proportionally. Shape, specifically elongation, is one part gets stretched out. So in this example, we have two different types of distortion. They're both elongation, but I should say two different ways to create that. Right? One is misalignment. This should be over here. And the other is the fact that the tube is angled. So this one is more extreme, right? When you angle the tube, generally you're putting more than 5 or 10 degrees on the tube, right? What's the lowest amount you've seen? Maybe the lateral knee? Lateral knee is what, 7 to something? 3 to 5?
3 to 5.
So like knee.
Yeah, just about everything else is more tube angle. Off the top of my head, I'm thinking, well, my different positionings, right? The second lowest one might be well, what? Foot is 10, 15. Clavicles are what?
15, 20.
15. Yeah. So off-centering only changes the angle of the tube. Well, the tube is not really angled, but it's the equivalent of angling the tube by a few degrees. We'll see that coming up. So yes, of course, it's not always possible to keep the part parallel and the tube perpendicular, but if we could, that's what we should do, right? I mean, if we keep this parallel to the image receptor and the tube perpendicular, so it kind of creates that T, that will give us the least amount of distortion. But of course, that's not always possible, right? And you can only really try to do your best on that, right? Because not everyone's bone falls exactly parallel either. When you're doing a femur, one part, the distal part of the femur, is closer to the cassette than the proximal part of the femur, where your actual femoral head is. So you have an actual bone that is at an angle already, it's kind of diagonal. And there's not much you can do about that. That's, just kind of how we're made, which is works out well because we can walk and do all these things, right? So I wouldn't change it, right? There are some general rules. The thicker the object, the greater the distortion. And spherical anatomy, like your skull, illustrates the most distortion. There's not a lot of compensation that you can do for objects that are spherical, like the cranium or like the head of your femur or the head of your humerus. And we'll see that in a second here. So if you have a bone that's flat, you can actually have a situation where you don't have a lot of magnification. So I'll explain this, but let's just look at the bottom first. So you have an object. Those are both the same size. your projected object size is both the same. You would expect there to be elongation here because you have an angle. Right? It doesn't matter what the angle is, but you have an angle, so you would expect elongation. But because it's nice and flat, we don't see a lot of distortion, right? In fact, based on these numbers alone, we don't see any distortion, right? So if we have objects that are thin compared to your cranium, let's say, then we should see very little distortion, even with an angle. Especially if, notice there's an angle on the beam, but we are still perpendicular to, sort of, to the object. Foreshortening is the other type of shape distortion, right? This is where things kind of get compressed. You can see here, because the object is tilted, it's no longer perpendicular to the tube. This is also somewhat scary in that on the image, something shows up a lot smaller than it really is. So if that's pathology, it looks like there's not as much of it. I wouldn't like that. Let's just cut out part of it and leave the rest in. Not good. So, again, you can't do much with this sometimes. If someone's elbow is stuck like this, you just snap it in place. No, not nice. What you could do, right, is turn this way and turn the tube this way. So everything becomes perpendicular and parallel. That's easier said than done because the object is inside the body. You don't know what the obliquity of it is. And we can't take x-rays to take x-rays, right? I knew someone that did that, though. I think they fired her. She used to fluoro and then take an x-ray. Right, so she could see where the, like, to get the hip right in the middle of the image, she'd fluoro, find the hip, and then take an exposure.
They literally tell you to not do that in the book. It has a term for it, actually.
Oh.
It's like a term.
There's a term?
Yeah, there's a term, like, that you're not supposed to do that.
Yeah, foolish would be an understatement.
It was somewhere else.
Yeah, we don't want to do that. Right? That was never a standard. Never, never, ever. It was a remote room. So we'll talk about this when we get to fluoro, but it was basically a remote control room from outside. So it was very easy for her to lay the patient on the table, control the fluoro with the joystick. I won't get too much into it, and kind of see where she was without the whole, apparatus thing that we have in room 1. It was very easy to fluoro. But still, that's a huge exposure, unnecessary. Right. So who was I talking to in the hallway earlier? Was it anyone here? It was related to fluoro. Oh yes, okay. So you guys are learning now this semester with Professor Vianacore fluoro stuff, right? GIs, BEs. Oh, not yet. Well, you will, right? And she's going to tell you, the typical types of exposures that we make, the different types of overheads. Like for a GI, you do an LPO, you do a lateral, you do an RAO. But very often, the radiologist who initially starts doing the fluoroscopy can see the image basically live, can move the patient to just the exact obliquity and remove certain superimpositions of structures to get exactly and isolate an area that they want to see perfectly. Where we can't, right? We go with sort of exact, or it's not even exact, but we go with certain, standard obliques, right, at certain angles. So the radiologist will often see what they want, and also now it's very easy for them to take essentially a radiograph, right? You can switch from fluoro to a static image like instantly by basically pressing a button. So in a lot of cases, you'll see this, which is kind of unfortunate, but maybe not so bad for the patient in reality. A lot of times we're not doing the overheads because they essentially, so when I say overheads, that's kind of the term for like our turn to take our x-rays. It used to be radiologist goes in there, does a bunch of stuff, then we would go in and do a bunch of stuff. And now we're not doing as many radiographs because the radiologists can get and see what they need. So I always have this dilemma. This is what I was explaining. I'm sure other clinical instructors have the same problem. Sometimes I'll ask the radiologist or the med student or whoever is fluoroing to allow the student to do the overheads. My dilemma is, one, if they didn't need them to begin with, then I'm kind of overexposing the patient, right? I mean, why should we take more x-rays? But then again, it's school, and none of them have ever said no to me, because it is a learning environment. But I always feel like every time that happens to me, and it hasn't happened in a while, I'm always like torn, to ask the student to additionally irradiate the patient. Of course, I've also seen the other side, right? I've seen people who don't know how to fluoro. They're just learning. They really want to be like dermatologists, but they're going through radiation radiology department, and they use like 10 times more fluoro than they should. You know that little 5-minute timer? Have you seen that yet? Yeah, have you ever seen it go off? Yeah. So, sorry to go on a tangent there. So, someone pronounce this for me? Who's Ceiszynski?
Yeah.
Everyone's good with that?
Ceiszynski.
You sure?
Ceiszynski?
Yeah? Okay. So we did this in the lab. Do you guys remember? This was one of my favorite labs last year because everything all works out. The idea here is that we can remove some of that foreshortening, provided, this is the big thing here, if we know the angle that the object, in this case, in this example, it's a sacrum, if we know the angle that the object makes with the image receptor, which in this case is 30, we can then place what's known as an isometric angle on the tube, which means we take half of what the angle is that the part makes with the image receptor and place that onto the tube. So if this is 30, tube angle becomes 15, and that will reduce, if not eliminate, the distortion. So the way we did this in the lab was by using the coins, right? You remember we had to tape them on the sponges and all this kind of stuff to make it work. A was the original object, right? Perpendicular tube and parallel to the image receptor. So this is kind of like our baseline image. And in this example, in B, the coin was tilted 45 degrees. So here's our foreshortening. It's like squished, right? C, the coin is tilted 45 degrees from the receptor, and the CR is perp. Let me see. C, the coin is tilted 45 degrees from the receptor. What was the difference between B and C?
Right, that's what I'm trying to find out. The CR.
In B, the coin is tilted 45 degrees while the central ray is kept perpendicular. In C, the coin is tilted 45 degrees from the receptor, and the CR causing elongation. Oh, okay, so C is an example of this, I think. D is where we use our Ceiszynski's law of isometry. Coin is tilted 45 degrees, and we take half of that, being 22.5, which is very hard to find, right? I mean, how many tubes give you sort of decimal fractionated angles? But I remember in the lab we got pretty close. And image E illustrates that no distortion occurs when the central ray is angled 30 degrees. Oh, so E is an example of, no, not this one. E is an example of this. E is an example where, because it's so flat, even though there is an angle, the distortion is not there. It's eliminated or minimized to where you can't even tell. Right? But D is the one I'm happy with. Right? Really shows the law there. But you can only do that with flat objects. Spherical objects, like we were saying at the very beginning, are very difficult to figure out because there is no real long axis. So if you go back up again to here, right? If we take half of the angle formed by the long axis of the object, the problem in spherical land is no long axis, right? So we're getting elongation. Not much you can do there. And maybe this is the most important slide of the day, because in clinic, I see this all the time, right? Have you learned HIP yet? Mm-hmm. Right? So you think you might be doing the right thing, right? You turn the hip in and, provided there's no fracture, you broaden the hip and all that good stuff. But if your image has like no neck to it, how are you going to see a femoral neck fracture? This is a diagnosis that gets missed a lot of times, right? Hopefully they figure it out, because a lot of times when you have a fracture, one leg is shorter than the other. Seriously, no joke. So that's a physical sign, right? That probably one of the reasons why they send you to the X-ray department, right, to confirm. Right? Besides the fact that the patient's in pain, but that's not really that great of an indicator, right? Because pretty much everyone's in pain after falling down and coming to the emergency room. So that's kind of like a given, right? But a size difference is something more obvious. And this can happen all the time because, one, right, your hip, really the head of your femur coming into your acetabulum is kind of like an angle, right? Today is where I really need the skeleton, right? Where you would be able to see, articulate skeleton, where you'd be able to see it. So there's already an angle on the bone like we were talking about before, and that's already going to cause foreshortening, right? Without doing anything, really. So a lot of times you'll get an image like this versus F, which is a much better image, right? I wish they kind of showed the rest of this here. It would look just as bad. So F projects the head of the femur. CR is perp, as it should be. G is showing us elongation. The CR is angled 30 degrees. Well, we shouldn't be angling the CR 30 degrees. I don't think that's in the book at all.
And because it is angles, is why it's missing the neck and everything out, because of the natural angulation.
Part of it is the natural angle, but most of it is the obliquity placed on the tube.
Right.
Right? Because this is possible, right? If it was all just the anatomy, then we'd never see F, right? We would never see F. It would never be possible. And then we'd have to, figure out other ways to diagnose.
Can that be caused without creating an angle on the tube? Like, could it be by, I don't know.
Yeah, if the
Position.
patient is obliqued in a certain way, that can cause the foreshortening, right? And that happens a lot too, because patients come into the emergency room and it's like you don't really want to position them too much, especially if you have a fracture, right? Usually, I don't know if there's a technical name for it, but usually you kind of shoot as is.
Right.
Sometimes when they first come in, has anyone kind of seen this?
I've seen it.
Right? You don't even want to internally rotate, right? You just want to kind of get one image to see, like, is there a fracture? Because the really scary things about fractured hips is internal bleeding, not just the fact that you have a fracture, which is bad enough, right? You know, there's a lot of femoral artery. So the other thing that they probably look at is how black and blue is the area, which you may not see because they're wearing a patient gown, right? So this is what we had talked about before. To a lesser extent, your alignment can also cause distortion. Right? And this can happen in those very same hip x-rays, right? Because a lot of times you might not put the patient on the table. You might just get a slip-on grid or use the flat panel detector and just put it under the patient on the stretcher. It's certainly much easier in some cases when they're in a lot of pain and you don't want to put them onto the table. I try to get everyone onto the table. But if you didn't, you could certainly have your alignment off. And have you noticed that the flat panel detectors is kind of like one size fits all? They don't have like mini 10x12s yet. Maybe that'll happen one day. Right now, you know, you have a 14-17. So if they ask for a portable hand in the recovery room after the patient had some surgery and you go up there, you don't take out your nice 8x10 flat panel detector, right? You take out what you have. And so what I mean by that is if you have a smaller object, you're more like at a large image receptor, you're more likely to have your alignment off because you just kind of put it under there and you're like, I know I'm there. I'm going to get it. But this can possibly happen, right? So your alignment is off, and your alignment based on the divergence of the beam is going to be even more off if you're at 40 inches than if you are at 72. If you are at 40 inches, every inch that you are off in alignment is about 2 degrees of as if you were to have angled the tube without angling it. Right? So notice here, the tube is not angled, right? But every single inch, so if you are 1, 2, 3, 4 inches off of where the central ray should be, that's as if you angled the tube 8 degrees. If you are at 72 inches, everything is cut in half, right? So you would be off 4 degrees. That's the easier one to remember. Every inch is 1 degree. So we are facing lots of issues with our images. Between OID changes, to a lesser extent SID changes, due to misalignment, sometimes due to just the anatomy itself that's not always going to fall, you know, perfectly parallel to an image receptor, our images are full of distortion, right? But we do our best, and the radiologists do their best. You get to a point where a lot of that stuff is inherent, and you don't really think about it anymore, right? Unless it's extreme.
Well, this has to do with, I think, last semester you were saying something along the lines where there's a certain amount of degrees you're supposed to raise.
Oh, that's coming next.
Okay.
Yeah. I think that might be the next slide. Yeah. So to try in an attempt to keep our SID the same, there's a general rule, kind of rule of thumb, right? It's not like a physics law or anything that's serious, that once you go beyond 15 degrees, after that, you should change the SID by 1 inch for every 5 degrees of angle on the tube. So for example, at 25 degrees, so now you're past 15, how much more past 15 are you?
10 degrees.
You're past by 10, but for every 5, it's an inch. So that's 5 and 5, that's 2 inches, so you should bring your SID down by about 2 inches. And you can always use the sophisticated measuring tape to make sure you're still at 40 inches. This is not what you would utilize to try to fix misalignment.
Wait,
Right.
but, so, if, let's say you're at 40 degrees, it's perp, and if you're turning it, you're angling to 25 degrees, decrease the SID from 40 to 38.
So every time, was that the example? I'll say that one more time.
If you, so let's say your tube is perpendicular at 40 inches SID, but you're gonna go ahead and rotate, you're gonna go ahead and angle it at 25 degrees, 25 degrees, you're gonna drop that SID from 40 to 38 inches.
That's right.
Right.
Yeah, if it's perpendicular, you don't do anything.
No, right, but as soon as you
Right?
angle
As soon as you angle, I mean, we've probably done this in the lab. As soon as you angle, there's suddenly a difference in your SID, right? Which can change a lot of things, right? So to try to keep our magnification the same and to try to keep our exposure the same, right? Because we know SID has an effect on exposure. Then we try to maintain 40 inches at all times. Right? I mean, this is a rule that will help you on an exam, but in reality, you don't have to think of this rule. Just measure and make sure you always have 40. Right? Kind of easier than trying to figure it out. Even if you use this rule in your mind, you still want to confirm it by measuring. I would say. All right. No, wasn't too bad. I did better than expected. I can take attendance.
Wow, that's crazy talk.
That's crazy talk. Okay, don't go anywhere, folks.